Okay, everyone, we're going to get started. Thank you for joining tonight's webinar. I'm Michaela Titus. I'm the Center Director for the Northeast South Dakota Area Health Education Center. These webinars are brought to you by the South Dakota EMS Association, District 4, as well as Northeast South Dakota AHEC. We are excited to have Matt talk today about summer emergencies. We'll have a quick few announcements to begin with. If you have not registered in Image Trend, please either put it in the chat or send me an email. We can get that taken care of. If you need ALS hours, please send me an email. We can get those taken care of, as well as if you have any questions related to CEs related to this. Additionally, we will have a short survey at the end for you guys to complete that just asks a couple questions that we would love to hear your answers on, as well as the EMS Association has their awards that are due dates are July 1st. So go and submit any of your colleagues who you feel would be great for those awards that are all out there. You can go to the EMS website and we'll drop a link in the chat, but go check those out. The deadline is July 1st, so it's important to get those in as soon as possible. Without any further ado, I'm going to pass it over to Matt.
Well, good evening, everyone. My name is Matt Stroop. I'm a paramedic and I work for the Rapid City Fire Department. And I understand you wanted to talk about possible emergencies in regards to the time of year. We are currently entering, as in summer, and everyone gets out and about and starts to do all their favorite things, run into whatever sorts of emergencies, and call for either EMS assistance or, parks, recreational areas, bystanders, the public, and whatnot. So after looking at the request, I understand drowning was a desire to go over one of the topics. So let's go ahead and start there. If you'd let me know whether or not my screen is working.
Yes, we can see it. Oh.
Very good. All right. Well, as we all know, drowning. You have a patient who has entered water and becomes asphyxiated. This submersion into usually water. There can be, we also in EMS talk about the possibility of an industrial setting, tanks and those sorts of things. But most commonly you deal with patients who might be at the lake, the reservoir, a pool, in a community. And then they are deprived of oxygen from that aspiration, from the water getting into their airway. A near drowning is defined as an incident potentially fatal. This submersion into the water did not result in an immediate death. In the 24 hours post the event, post the incident, drowning is classified as something that happens in that first 24 hours from the incident. So there can be other associated conditions with drowning. We always worry about trauma. It's pretty common for folks to dive or patients to end up diving in head first and experiencing head trauma, an axial load injury onto the spinal column, usually the neck. And then you have a patient who is not only a trauma patient with a head injury, a neck injury, but now they're at a huge risk for aspiration and drowning because they can't get themselves out of the water. These patients are also hypothermic because they're in water, and water cools us very well through conduction, one of the methods within which the human body loses heat And so very serious situation. And then because they have water in their lungs, water in their airways, they're now a hypoxic patient. So in trauma, we worry about the trauma triad of death. Hypothermia is one branch of that. The other two being acidosis and coagulopathy. Those two conditions are not necessarily a concern in this situation, but hypothermia is, if you have a cold patient, they can't do multiple things. They can't, their ability for their red blood cells to bind to an oxygen molecule is hampered. Their ability to release the oxygen molecule from the red blood cell to the cells of the body is hampered as well. And because you have a patient who is not ventilating and efficiently or appropriately, they may, pardon me, they may be have a difficulty offloading their carbon dioxide, and they can become acidotic as well. So these are all concerns. Any healthcare provider, EMT, paramedic, nurse, doctor, anyone in the nurse practitioner, PA, anyone in the medical field always goes to, airway first, make sure that airway is patent, that the patient's able to ventilate, primarily to get rid of CO2, secondarily to bring O2 into the body, and then that they are able to ventilate adequately on their own. We all know that adequate breathing requires enough tidal volume in and out of the chest. So we need to move enough air in and out of the chest, and we need to do that enough times in a minute. So we're talking minute volume at that point. So the amount of air that you're moving in and out of the chest, the normal tidal volume that we breathe in and out, as long as we're not excited or, in an increased metabolic state, is about half a liter, about 500 mLs when we're at rest. And normally we breathe about 12 to maybe, depending on our body habitus and our medical condition, maybe up toward 20 breaths per minute. So, anywhere from 6 to 10 liters per minute is being, moved of air is being moved in and out of the chest in adequate breathing. Now, if you have a patient who is injured or near drowning, they're going to be obviously moving a lot more air faster, and their minute volume is going to go up. There is a situation called a dry drowning versus a wet drowning. And the only difference really is that a dry drowning patient will have a laryngospasm or laryngospasm, depending on how you pronounce it. That's where the larynx, the vocal cords actually contracts, will spasm closed, and this will help to prevent a great amount of the water that, lake water, pond water, pool water, whatever it is, from getting down into the trachea and into the airways, the bronchioles, and out into the alveoli. You do have, and we'll talk about freshwater versus saltwater. I know, here in South Dakota, we don't have a whole lot of saltwater drowning, but we still talk about it. Wet drowning, then we don't, that's a patient that doesn't have that laryngospasm. And then the, water, whatever the source is, gets down into the trachea and down into the bronchioles and out into the alveoli. Another issue with getting water out into the little air sacs, our alveoli, is the water will wash out our surfactant, and surfactant is very, very necessary for our alveoli to work adequately. It doesn't surfactant doesn't hamper the exchange, that respiration between the alveolar capillary membrane and that exchange of CO2 and O2, but water does. And so surfactant is good. It helps keep our alveoli open. Water washes that out, and we can get collapsed alveoli. All of us being in the medical field, I'm going to post my first question. What is the term for a collapsed alveolus, or we can use this term for a collapsed lung as well? What's the medical definition, the medical word for that collapse of alveoli or the lung itself? Anyone ever heard of the term atelectasis? That is the term. There it is. Good job, Tim. Yes, atelectasis is the term used for collapse of an alveolus and collapse of a lung. Really, for both, that term does apply. So freshwater versus saltwater, it does differ. And obviously, that salt in the water pulls water out of our bodies. And our bodies are designed to have water follow sodium wherever the sodium may be. And so sodium in the salt and the water that now has made its way down into the lungs can pull water out of the body tissues and dehydrate them, damage them, and kill them, and cause ischemia and necrosis. So we neither drowning is good, but saltwater drowning can be a little bit worse. It can cause more tissue damage. We do have a mammalian diving reflex. This is where our face and nose become completely submersed in water. It can constrict blood flow everywhere except the brain. It works better in a cold water drowning situation. Like I said earlier, a big concern with a drowning or a submersion incident is the hypothermia the patient may be experiencing. The interesting thing about hypothermia is it lowers the metabolic rate of the body of all the cells, and we may not necessarily have as much damage happening or injury happening to the patient because they are hypothermic. And so a cold water drowning or a cold water submersion incident may be an incident where we will enact or perform a longer resuscitation effort. We will work harder, do CPR longer, warm the patient. We may not give as many medications during the hypothermic portion until our patient's warmer. We do use electrical therapies, defibrillation and even cardioversion if necessary. So this is one of the instances where we may have a longer resuscitation effort. Lightning strikes would be another one because the lightning, can anyone tell me what, if you have a patient that's struck by lightning and, they are now unconscious, unresponsive, don't have a pulse, what cardiac rhythm can you expect that patient to be in? What kind of a rest rhythm might they be in? Tim says it might be VFib. The interesting thing about, and I know I'm kind of going a little off topic, but this is a lightning strike falls into, summer emergencies. So obviously you can have patients that are out hiking, experiencing our great outdoors and get struck by lightning. It would be an arrhythmia. It would be the only true arrhythmia. It would be asystole. Most often patients who are struck by lightning end up in a true asystole, so flatline. And the reason is because it's direct current electricity. Tim, good guess with the VFib there, but those are usually patients that experience an alternating current or AC shock, say a light, an outlet from your house, or, patients that or people who may go and work on the circuit breakers or the electrical panel in their home, or an electrician for that matter, or substations within, communities. They're most often going to experience that alternating current, and that almost exclusively puts our patients into VFib or maybe a pulseless VTAC. And those are the patients that need our electrical therapy. We defibrillate those patients. We never defibrillate an asystole patient. There we do CPR and give epinephrine, and then figure out why they arrested. So good guess. So once again, in a submersion incident, a drowning, and your patient unconscious, unresponsive, we try to warm the patient so that maybe hypothermia is not necessarily one of the precipitating factors to their arrest. So We remove the patient from the water. This is, to be done by lifeguards, rescue swimmers, people who's this is their specialty. If you're on the beach, we row in a boat if we have to, so you can throw them a rope or maybe extend, reach, throw, row, go, are all the things that we do when we do water rescues. So you can help to initiate ventilation while the patient is still in the water. So here they're saying we don't wear protective clothing in water less than 70 degrees. You really want people who are trained for this type of rescue. If we have a patient who could have been diving, you always suspect the head and the neck injury. If you don't know, we treat for it and until it can be ruled out. Get a patient on a long backboard. Most of the backboards that we use nowadays are plastic and most of them float. Most of them are buoyant and so can help get our patient out of the water. We use cervical spine precautions throughout our care, so application of the collar is important. And then we got to warm the patient. You don't want to burn them, with your attempt to rewarm them. So be careful of that. But you do want to initiate heat to the body, and if you can get it to the skin, that's best. If you're able to get the patient into, obviously I work on an ambulance and that's our office, so we get the patient in the ambulance and then they're trauma naked. All the clothes come off and we get all those wet clothes off. That does several things for us. One, we get to do a full exam and look for any other injuries that may be there. We also get to get that wet, cold clothing off of the patient that's promoting that hypothermia. And then, now we also have less water on the patient. We can get them fully dried and we're not losing as much heat through conduction and evaporation. So that's obviously you're not going to do it right out there on the beach. You can remove pants, leave swim trunks on, a top if necessary, those sorts of things, but you try to get your patient as warm as possible. So we look for that airway, make sure that it's patent, it's open, assess their respiratory effort, whether or not they're actually breathing, and whether or not your patient has a pulse. People can still have a pulse and maybe not breathing. The converse is not true. So you may be in that window when the patient stopped breathing, but the heart's still going. There was enough oxygen in the blood to keep the heart going. So then we would do rescue breaths, and we would do a rescue breath every 3 to 5 seconds. Then giving the patient, the best option to ventilate and then monitor that pulse. If there is no pulse, then we begin CPR and we evaluate them with an AED or cardiac monitor for defibrillation. Keep that airway open. We suction. We use airway adjuncts, OPAs, oropharyngeal airways, or nasopharyngeal airways. Or if you're trained, we use things like supraglottic airways. Or if you're a paramedic, physician, flight crew, you may go ahead and intubate the patient. You'll give 100% oxygen if you have it available. And then you also try to rewarm that air if possible. That's one other technique for rewarming a patient, is you can warm and humidify oxygen. So that's a possibility on some ambulances. Obviously, in our case, we would start an IV. We like lactated ringers. If you don't have that, then normal saline is appropriate. And they recommend about 75 mLs per hour. Obviously, we'll titrate that to blood pressure to try and keep their pressure up. We like blood pressures around 90 to 100 systolic. If any of you understand mean arterial pressure, minimum of that is about 60, 65. And that's an average of both the systolic and the diastolic pressures, the top and the bottom numbers. So we like that. And there is perfusion in the body happening while the heart's at rest. There still is pressure inside our arteries, and that does help to perfuse our cells within our body. If you're trained in advanced cardiac life support, ACLS, you'll go ahead and follow those protocols until you get the patient warm. If the patient's hypothermic, you'll treat according to your hypothermic protocols. And warming them is a big part of that. If a patient experiences a near drowning emergency, they should be admitted to the hospital for observation because they can develop ARDS, acute or adult respiratory distress syndrome. There are severe complications from this. They may have fluid leaking from their lungs into the alveoli. Post resuscitation, this is a very critical part, very critical phase of this emergency, and may be necessary to have advanced life support, higher level of medical care available, and even things like a hyperbaric treatment might be necessary as well. Here in Rapid City, I know we can do that at the hospital here. I believe in Sioux Falls as well. I'm not sure about the rest of the state. I can't speak to that. So real quickly, we'll talk about diving emergencies, scuba diving, if they're underwater and they have, the appropriate apparatus. Obviously, they're down deeper in the water. There can be great emergencies, and then they can also have emergencies following a dive. Hopefully, they weren't in a submersible and going down to look at the Titanic, because apparently that's a pretty hazardous venture. So we don't have to worry about that too much here in South Dakota. Surface injuries, they might be caught in the lines of their scuba equipment. They might be caught in some of the plant life, kelp fields. Cold water can cause shivering or blackout. They could be injured from a boat. So there are a lot of things that can happen. They can have barotrauma during descent. This is where the pressure changes. You might see some difficulty in their nasopharynx or their middle ear. They can have ear pain. They can have dizziness. They can have tinnitus, the ringing in the ears. They can have hearing loss, severe headache. They can end up with a nitrogen narcosis state of being confused, stuporous, where a deeper dive causes that nitrogen to affect their cerebral function. They may appear intoxicated. They can end up with these sorts of things. They can get hypoxic if they do run out of air. So all things to watch out for. If they start to come up too fast, they can undergo a decompression illness. This is where that nitrogen begins to diffuse out into our body tissues and then causes problems when the diver returns to the surface. You can cause pressure trauma to the lungs themselves. And then you may see things like an arterial gas embolism. So they end up with an air embolism in their arteries, and it's from a damaged lung. So a pneumothorax, that's where air is inside the chest, outside that lung tissue, in between all of us right now have a potential space between our lung and the inside wall of our chest. But if you get air in between those structures, you can develop a pneumothorax that can worsen and into a life-threatening condition called a tension pneumothorax. And a tension pneumothorax is when that bubble, that air in between the outside of the lung and the inside of the chest wall gets so great that it pushes on the vena cava, and now we have less blood returning to the heart. And your patient experiences a low blood pressure, hypotension. Pneumomediastinum, that's where we get air into that center channel, that center cavity in the chest where our trachea, heart, aorta, vena cava, esophagus, all that lives in that mediastinum. And if you get air into the pneumomediastinum. Interesting note, what situation outside of drowning could a patient be active in where they end up with a pneumomediastinum, air in the center chest cavity where our trachea, that's another clue, our bronchi, the right and left main stem bronchi, all that lives. What recreational activity can a patient be involved in that could cause a pneumomediastinum? I learned about this about 10 years ago when I was working in Colorado, around the time that well, it was a little while after that Colorado had legalized a formerly illegal substance. There's another clue. Patients that smoke a lot of marijuana, they'll try and hold that air marijuana smoke in and not cough. And they'll have such a high level of smoke and toxins in their bronchial tree that they will cough really hard, and they can actually tear the lining of the trachea or a bronchus, sorry, and release some of that air into that center chest cavity, and they'll end up with what we call a pneumomediastinum. It's kind of somewhat common, and it's not like folks in our country are using less marijuana. So it is something that is out there, and hopefully you never run into it, but it's an interesting etiology. So things to note. Sorry, was there a question?
Yes, is this kind of the paper bag effect?
Kind of, yeah, yeah. The lung being the paper bag, sure. And that pressure can be, too much, and you can tear. Even a small tear can cause pneumomediastinum or even a pneumothorax. So people with COPD, especially emphysema, they have delicate lungs from their disease process. And I've had COPD patients, emphysema patients who smoke pot, and a couple of them made themselves markedly sicker doing it. But some folks just can't give up whatever their drug of choice is. So, and then that's when they end up calling EMS when things go south. So, but it is what it is, and we do the best we can as medical providers. So things to note: if there is a drowning or near drowning incident, time at which the signs and symptoms occurred, if they are using scuba gear, what type of breathing apparatus were they using? Were they hypothermic? Sorry, our fire station here is going off on a call, so I won't be going with them. I'm going to stay with you guys.
I got one more thing to add. Maybe you were going to
Yeah.
touch on it, but if
Sure.
you have a dive injury, make sure you take their dive computer with the patient.
Sure. Yes. Yes. There could be a record on their equipment. They could be helpful, especially if there was that emergency. So good point. I didn't say that. So obviously, whether or not your patient had hypothermia protective gear, what kind of wetsuit they had on, that might be something that you have to get off, or dry suit for that matter. And then if you know this, like you were just talking about, what were the parameters of the dive? What was the depth? How long were they down? So, and aircraft travel following a dive is a dangerous adventure. It's a dangerous thing to do. They don't recommend it. So we look at things like the rate of ascent. Was there panic forcing a rapid ascent? Are they an experienced diver? Do they have medical diseases or conditions? Were they using medications or alcohol? Nobody ever uses alcohol when they go out on the boat, right? So those can all be confounding factors and cause worse illnesses. So worsen their condition or their injury. Decompression illness, this is when they had that rapid reduction of air pressure after ascending to the surface. Signs and symptoms of pressure disorders: joint or abdominal pain. They can have fatigue, paresthesias. They can have central nervous system disturbances. Treatment, we try to recompress the patient to a greater pressure. How's it going? We can use a hyperbaric oxygen chamber, and that's what I was talking about earlier. That can help resolve some of these issues. Decompression illness, obviously with any patient, you're going to monitor their ABCs, airway, breathing, circulation, CPR if required, O2 at 100% concentration. Any unconscious diver should have advanced life support there and have the patient intubated. Keep them in a supine position. Try to keep them normothermic, keep their temperature where it should be, no excessive heat or cold, no noxious fumes, obviously. And then if the patient is alert, oriented, able to protect their airway, able to swallow, we can give them fluids, water, fruit juice, maybe even salt solutions. We stabilize the patient, get them to the nearest emergency department, and then evaluate them whether or not they need that hyperbaric chamber. We may try IV fluids with electrolyte solutions. If we do note some central nervous system involvement, they give dexamethasone. They may give them heparin to avoid clotting, or Valium as a sedative agent. So those are medications that may be ordered by a physician. If they do need air transport, we want to keep them in a pressurized cabin, at least at sea level, and they'll keep them at the lowest, safest altitude possible. So that's if they are to be transferred via an air ambulance. So, and then their equipment may need to be evaluated. So I talked a little bit about arterial gas embolism. This is an air embolism that enters the circulatory system. That air in the circulatory system doesn't allow the circulatory system to move like it normally does. Fluid and a gas do not move the same, and it can present basically like a clot. You can have damage to the lung for an overpressure incident. And then patients can experience things like a sharp tearing pain, confusion, vertigo, difficulty with their vision, full loss of consciousness. And like with any patient, we'll monitor their ABCs, treat any of those. Those are always life threats. 100% oxygen, supine position, maintain their vital signs. If they are awake, able to talk, protect their own airway, swallow. We can try IV, I'm sorry. If they're not awake, not able to maintain their airway, we would give them an IV and TKO that to keep open and monitor it for blood pressure. And there are corticosteroids that we might give, and then get them to a hyperbaric chamber as soon as possible. Any questions over drowning, diving, that sort of thing? That was a quick overview. I know there's a lot that we could be talking about. I was going to go over drownings and diving emergencies, and then also heat related emergencies, and maybe a little bit about dehydration as well, because it's that time of year for it. So any questions? If not, we can move on. All right. Well, let's see here. Shall we talk about some heat related emergencies? We'll talk about heat emergencies. We'll talk about 3 methods to rid the body of excess heat. We'll talk about poor blood flow to the brain and the most common heat related medical problems. We'll talk about the signs and symptoms of heat exhaustion. We'll talk about patients who might be susceptible to heat stroke and the signs and symptoms of heat stroke, and then treatment. So a little bit of review here. We'll go back to biology class. So your anterior hypothalamus, the portion of the brain that's responsible for regulating body temperature. And remember, this is the center of the brain, just above the midbrain, pons, medulla oblongata, the brainstem. And this all has all of our important life functions. It's all highly protected, has a big bone box around it, has other brain tissue to help protect it. So that's very important. Conduction is the dispersal of heat or salt into a solid or a liquid. So you're touching something. Convection is the loss of heat to air. And to some degree, if you're in water, convection can also pull. It's the method by which liquid pulls water or pulls heat out of your body as well. Dehydration, we lose body fluids. This can predispose your patient to hypoperfusion, also known as shock. So now we have less blood volume, and it's not able to perfuse all of the body tissues, and the body begins to suffer. Most all of us are a little dehydrated every day. because we don't drink water throughout the night. We wake up about 10% dehydrated first thing in the morning. One of the best things they say you can do for your body, besides getting a good night's sleep, sleep is more important than diet and exercise combined, is to go ahead and when you wake up, drink a full glass of water and get the body's a little more hydrated and get the body's metabolism going. Evaporation is a cooling effect, which through which our body uses sweat to release heat to our surrounding environment. Radiation, we just breathe, we just emit heat off. It's different than evaporation. Evaporation pulls it through the sweat. Radiation is just happens from the heat of our body coming off. And we all have been around a radiant heater or stovetop, and there is that heat that radiates away. Anhydrosis, this is where patients don't sweat. And there are some people that don't do this. Now, in one of the heat emergencies, your patient will stop sweating, and that'll be one of the clues. There are about 4,000 heat-related deaths yearly. This was in, I think, the last statistic I saw was in about 2020, I want to say. About 5 per million over the age of 85 to 1 per million in the 5 to 44 age group. So our older folks, if we're over 85, they do not tolerate the heat very well at all. And if it's hot out, they're going to talk about it. So you know that the elderly above 85, yeah, they need to be, you know, cognizant of what's going on in the shade, maybe in a cooler environment. You know, less exposure out in the sun, all of those things. It can be the second leading cause of death among young athletes. We all hear every year somebody's out, you know, to track meet, a baseball game, soccer match, whatever, and you know, they're out there expending all these great amounts of energy in their sport, and they end up with heat emergency, and it does kill some folks. Under 4 years old, they're at an increased risk, like our 85 and up. There's quite a risk for little babies under the age of 4. They're not able to tolerate or regulate their body temperature as well as those of us, you know, 5 years old up to about 44, the prime of life, as they say. So I like to, I'm pushing that out, and now I think it should be out into the 50s, but that's just my personal, being in my 50s, I think it's more important. So let's see. Anyway, if it's humid out and combine that with heat, you know, patients may need to reacclimatize themselves to this situation. Heat exposure, we can, you know, this here is there's 4 quarts to a gallon, so we're talking a full gallon to up to 4 gallons of water per day, depending on the type of work they're doing. You know, I was driving through some of our road construction the other day, and it was good and hot out, and those folks looked like they could use an air conditioner and a cool drink, cool glass of water. So salt consumption should be slightly increased. We don't want to lose that salt. What does everybody seem to want to do when they're out in the heat? They want to drink what type of fluid? Pop's common, sure. Yeah, soda, pop. Yeah, what else? Alcohol, sure. Yeah, everybody's, you know, I want a cold one, right? Yeah, and that's not uncommon. Sure, that's another one. How about Gatorade? Everybody wants sports drinks and Gatorade. What's the problem with Gatorade, especially in a patient who may be out in the sun, hot environment? Does it really rehydrate us? Does it prevent dehydration? This is the audience participation part of the class. This is where you guys get to play too. So Gatorade is great, except that it's way too concentrated. All that sugar in Gatorade actually dehydrates your patient. And Gatorade should be cut with, 1-to-1 with water at the very least. It's much better with like 4-to-1 with water. Sporting events, yeah, they use Gatorade, except they put a lot of water in it. 4-to-1 is pretty good. You're getting the electrolytes, some of the salt back, and water with it. But when it's, concentrated like it is right off the shelf, man, there's way too much sugar in there, and that high sugar content's actually going to pull water out of the body. So it's not recommended, and they don't talk about that enough. So good to know. With a heat balance, like anywhere in the body, we offload heat through conduction, whatever we're touching. Convection is either water or air, usually air that pulls heat out of our bodies. That's why a fan or air conditioning feels so good in a hot environment. Radiation, we actually off that heat, radiate heat from our body, and then evaporation, that's why we sweat. So body heat equals metabolism. So if you raise the body heat, you're going to raise the metabolism. So here is a heat balance equation. So you add conduction and radiation, you add convection and minus evaporation. So in a lot of instances, evaporation is our only mechanism to regulate that heat. So it can be a big deal. Our one other concern is our pets, animals, cats and dogs really struggle with high extreme temperatures. They don't necessarily sweat like we do, and the panting is how they get the heat. They regulate their heat and are able to offload that heat from the environment, from their metabolism. And so that's something to keep in mind. We all know that it's a huge risk for an animal or a human being to be stuck in a hot car in the middle of summer. And that's one of the situations where law enforcement will break a window to get someone out. So our hypothalamus, it stimulates our autonomic nervous system. We have increased vasomotor tone. We get better blood flow up to our skin, and this helps offload some of that heat. If we stimulate the rest and digest portion of our autonomic nervous system, we get good sweating that can help regulate heat, but it also can dehydrate our patient. And then if our patient is adapted or acclimatized to this environment, they'll do much better. But if they're not, about 2 weeks ago, I drove down to Houston, and it's markedly different than our climate up here. 90 degrees up here, or even 80 degrees, which is supposed to be over the weekend, is pretty comfortable up here. But down in Houston, where it's pushing 100% humidity, markedly different. It's like you can't walk from your car to the house without sweating pretty profusely. If you're predisposed to a heat injury, you can experience increased heat production, and this could be from physical activity, could be from a fever, could be from medications or drugs, especially stimulants. And then we start to gain that heat. That high ambient temperature doesn't allow us to regulate our body temperature. And then that decreased ability to disperse heat is an issue too. So here's a heat index. This is something you see on the weather, on the news usually. And if you look here, we have the air temperature here and the humidity. The higher it goes, the heat index is increased markedly. And here with the lower, down into the 90s can be hazardous and extreme danger at 100% humidity. So we lose the ability to regulate our heat the more humid it is. So, I mean, you might just be tired in this yellow area, but you start with muscle cramps, heat exhaustion, that's here in this darker yellow, and dangerous in the orange, and extreme danger up into heat stroke. We're going to go into that next. Dehydration and heat disorders, it prevents our ability to offload that heat That's the medical term, thermolysis. Patients can present with nausea, vomiting, abdominal cramping or distress, changes in their vision. Obviously, if you're dehydrated, the best way to determine if you're hydrated is to note their urine output. One of the best ways to keep yourself from getting a kidney stone is to pee clear, drink enough water so that your urine is clear at least once a day. It can very much help from you to help prevent from you from developing a kidney stone. If you note skin turgor, where the skin may tent, that can be a sign of severe dehydration, and then our patient could progress into hypovolemic or low volume um, type of shock. So if your patient's awake, alert and oriented, able to protect their airway, able to swallow, we can try oral fluids. Things like water, a little bit of fruit juice can be okay. Um, um, Water mixed with some Gatorade can be good as well, like I talked about. But if they are nauseated or they're altered and they can't protect their airway, get advanced life support there, and let's start an IV. So things like confounding factors can be, for dehydration can be, obesity, heavy clothing, lack of fitness. They're not used to that environment, so they're not acclimatized. They can have cardiovascular diseases, burns, scleroderma, eczema, psoriasis, glandular disorders. We talked about the extremes of age, inability to move, fever, and then hyperthyroidism. Alcoholism can be a confounding factor. Drug use, any of your stimulants, cocaine, amphetamines, opiate, LSD, PCP, ketamine, all of those. Ketamine's on the street. Now, remember, there's a lot of fentanyl on the street, and that's a depressant. That's a sedative. It's not necessarily going to be a risk factor, other than it can cause altered mental status for your patient. Poor socioeconomic status, no air conditioning, multi-story building, buildings, with lots of brick and lots of people cooking, all the things, and it can cause increase in temperature. Medications like antipsychotics, anticholinergics, calcium channel blockers, beta blockers, diuretics that pull water out of the system, alpha agonists and sympathomimetics, so things that are stimulants. So those are all things to be aware of. Heat edema, we note some vasodilation, some swelling in areas that are dependent. This is a fluid in between the cells, usually found in the extremities. This happens in our elderly patients and patients who aren't acclimated to the environment that we're in. These are usually self-limiting, not necessarily as big of an issue. Hyperpyrexia, this is a fever, things that cause fever. Cooling the fever patient, the big thing you don't want to do is cool them so fast that they begin to shiver, because then now our big muscle groups are causing more heat to be generated within the body. Things like Tylenol, ibuprofen are great for fevers. And Tylenol you can give every 4 hours. Ibuprofen you can give every 6. The other way you can do this is you can give both every 6. That's easy, or one or the other. One every 3 hours, and then the other every the other one every 3 hours. So you can alternate it that way. That's good for kids too, as long as the dose is regulated to their weight. We try to avoid sponge baths. Here, prickly heat. So this can be things like malaria, heat rash. We get a rash by this inflammation, especially with our sweat ducts. It can be itching. They can get that's pruritus in this warm environment. And antihistamines can help for that itching. Some steroidal creams can help as well. If you don't treat this and it's prolonged, it can get into a dermatitis sort of thing. Heat syncope, this is a cumulative effect. They get that peripheral vasodilation. So now all of a sudden the container is bigger and the volume doesn't maintain a blood pressure as well. This can easily happen in our dehydrated patients. These are patients who aren't used to the environment. So you look for that diagnosis in any cause of syncope. If the patient's awake, able to protect their own airway, able to swallow, oriented enough, you can try rehydration. But if not, get ALS there and let us start an IV on them. Get them out of that environment, get them into the shade, get them into a cooler environment. Um, you know, heat cramps, they talk about this one as usually the first sign of a heat emergency, but other things like the pruritus, the syncope, the prickly heat, all that can happen before cramps. This is where patients will have difficulty with their muscles. They are changing, their electrolyte levels are changing. Usually it's sodium and potassium that they're missing. And then you can still maintain and treat a patient with heat cramps at home. Let's get them rest and rehydration as long as they're alert and oriented, able to protect their own airway. Tetany of any muscle is where that you have that spasmodic contraction. And so hyperventilation could cause respiratory alkalosis. You can get some paresthesia, carpal pedal spasm, the crab-like hands. This is when you have that vasoconstriction, when they're ventilating so fast that they are in a hyperventilation crisis. This can happen in short periods of heat stress. Let's get them out of the heat. Let's get them to control their respirations. Heat exhaustion, this is usually the next step after heat cramps. They're usually non-specific. Everybody is familiar with the WADEO acronym. That's weak and dizzy all over. They can have nausea, vomiting, headache, myalgia, so that's that muscle pain. They may also, you want to also see things like syncope, fainting, changes in their blood pressure. If you sit them up and stand them up and take it, you can see a fast heart rate, a sinus tach, fast breathing, some profound sweating, and obviously the temperature will be up. This is a diagnosis of exclusion. Obviously, we treat them with rest, get them out of the environment, and then they need an IV. They need to be cooled and they need to be rehydrated. Heat stroke, this is the life-threatening condition. This is where their temp gets up above around 105. They'll have central nervous dysfunction. They'll be unable to sweat. Now, initially, when they enter that heat stroke state, they'll be sweaty from the heat exhaustion phase. So they can be wet in a heat stroke situation, but it's usually the initial phase of it. If their temperature is way up and they're altered, that's heat stroke until proven otherwise. And the big thing is you gotta get them treatment fast because we can have neurologic damage. And we don't want them, with brain damage. So the central nervous system, they'll present irritable, may have bizarre behavior, they may be combative. Your cerebellum, the portion of the brain in the back, the term cerebellum is Latin for small brain. It is very sensitive to heat. Patients will have difficulty with their balance and walking. They can have swelling in the brain. And then, like I said, that inability to sweat can be a later sign. So at this point, their temps above 104, around 105, and they have total breakdown of their ability to regulate their temperature. Their thermoregulatory mechanism is done. They are just too hot. And if we don't intervene and we don't actively get that patient's temperature down, get them rehydrated, like I said, they'll have brain damage. Heat stroke, it has a slow evolution, might be hard to see. They'll have too much heat gain from the environment and not enough heat loss or dispersal. Like we said earlier, elderly patients, those are the poor socioeconomic status, infants or chronically ill, those are all the patients that will be at greatest risk. So if they don't have air conditioning, they have cardiovascular disease, they're older, and they're on any cardiovascular or anticholinergic drugs. Vigorous activity, I'm sure you've all seen, like running events, like marathons, and they have that occasional patient who, gets dehydrated, maybe approaching heat stroke, can't walk, altered, not good. So Obviously, as with any patient, we protect their airway, their breathing, circulation, get them oxygen, keep an eye on that oxygen level. We'll do a 12 lead EKG, get IVs, start giving them fluid, and then we monitor their temperature. You can use evaporative techniques to get them. Immersion can work. We don't necessarily want to place them in ice or super cold situations because then they can start shivering. But you can put ice packs and cold packs like in the axilla, in the groin, under obviously using a towel because you don't want to cause a frostbite injury as well. They do gastric lavage in the hospital. They can do a peritoneal lavage where they actually in gastric lavage, we put cooling water into the stomach. Peritoneal lavage, we'll put cooling solutions into the abdomen. And then there is cardiac bypass, but all of that is next level. So complications of heat stroke, you can get a patient, can go into heart failure, swelling and edema in the lungs. They can have cardiovascular collapse. We can injure the liver. We can injure the kidneys. That breakdown of proteins can clog up the kidneys and also in the blood. And then they'll obviously go into renal failure. They can have little hemorrhages throughout the body. They can have clotting disorders. Their platelets can get out of whack, and then they start to bleed. And then we lose fluid and electrolytes, and that can obviously kill our patients. So like I've said, heat stroke is a medical emergency. Need to be aware of it, that heat exhaustion can progress to heat stroke. We can use wet sheets. If there is no good airflow, if without good airflow, you can increase the temperature, so be careful of that. Do not let cooling in the field delay transport. Cool the patient while en route. So good AC in the ambulance is a big deal. Any questions about anything we went over tonight? And I hope that's what you were looking for. And I didn't even go overtime.
If you have any questions too, you can always throw them in the chat and we can let them. There are a couple of thank yous and great refresher on the info. Well, if there's not any questions, once you close out of Zoom, you'll be prompted with a survey on the Zoom website. So if you could please fill that out, that'd be greatly appreciated. And that is all. So have a good evening, everyone. And thank you again, Matt. We appreciate it.
Absolutely. Everyone be safe. Take care of yourselves. Have a great summer.